Hi, I'm Dr. Alan Brown, past president of the National Lipid Association and clinical professor of medicine at Rosalind Franklin School of Medicine and Science in Chicago. And today it's my honor to host Dr. Robert Hegele. Robert is in London, Canada. He's a professor of medicine at Western University, and he runs a lipid clinic at the University Hospital, where he is an endocrinologist. And I'm sure all of you know his reputation as being a real genius when it comes to patients with severe hypertriglyceridemia. So thank you so much, Dr. Hagley, for joining us today.
Well, Dr. Brown, so please call me Rob, and if I can call you Alan, that would be great. And it's my honor to join you.
Well, thanks. Of course, you can call me Alan, and I'm proud to be able to call you Rob. So we have spent some countless hours together talking about patients with severe hypertriglyceridemia. I'm
Yes.
excited about several things. I think we both lamented about those patients with familial chylomicronemia syndrome that, we've tried our best with very low fat diets, and we haven't had a lot of options because the medications don't work too much with them. So maybe today we can talk a little bit about the plight of those patients, and then I'd love to hear the data that's being presented on the Palisades trial
Right.
and what hope that gives for these patients that have really led a miserable life without a treatment option.
Yeah, definitely. Fortunately, so the familial chylomicronemia syndrome, it's a subset of the patients with chylomicronemia. So actually, patients with chylomicronemia, and then my colleague, has looked at it. So once you get triglycerides around 1,000 or more, that's where chylomicrons start to appear, fasting chylomicrons. And the commonest way would be like what we used to call type 5, or like multifactorial chylomicronemia, which actually is genetic, but it's just not Mendelian genetic. It's polygenic. But then a subset of those severe like severe hypertriglyceridemia, chylomicronemia, is actually follows the laws of Mendelian genetics. And so there's the two copies of defects that affect lipoprotein lipase about 80% of the time, or one of its cofactors, the famous ApoC2 and, ApoA5, LMF1, GPI, HBP1. And on a population basis, those patients with the two knocked out copies of one of those key genes, fortunately, it's around 1 in 100,000 to 1 in 1 million, and they start to be affected in childhood. And although, sometimes the presentation is later, can be, or, sometimes adolescence, or I've even picked up a few that were not even really recognized until adulthood. But generally, the classic presentation, yeah, they're, children, failure to thrive, like really sick, hepatosplenomegaly, lipemic plasma, like in hospital with, nausea, vomiting. And then somebody looks at the blood and it's lipemic, and then that's the classic way. And then those patients, then, just as you said, I mean, the mainstay of treatment has basically been dietary, and it's been a very nothing else works because of this fundamental, core biochemical defect. So nothing, omega-3 omega-3 fatty acids, fibrates, statins, nothing. So finally, so see, these patients, their quality of life is extremely compromised from a young age. They're thin as a rail, they eat like a bird, and yet, they're still kind of like the sword of Damocles hanging over them because of the pancreatitis risk. And then, so now finally, in the last, few years, with the biologic therapies, these targeted biologic therapies, we are, you know, making a bit of a breakthrough, some really meaningful, transformational treatments for these patients.
That's really interesting because, as you pointed out, the majority of the true familial chylomicronemia patients have a lipoprotein lipase. They're homozygous, right? It's a
Yeah,
recessive trait for
correct.
lipoprotein lipase,
Yep.
and that makes up about 80% of them. And yet the breakthrough in science has been that if you remove ApoC3, they get better. And
Yes.
I think that was accidental. You probably have some insight in that because you would think that if you
Yeah.
remove a protein that inhibits lipoprotein lipase in a patient who's got broken lipoprotein lipase, not much would happen, but
Yes.
it did.
That's absolutely right. And so then this is so in fact the study of I mean ApoC3 is a super interesting little protein. So even going back to the 1980s, when they were looking at the biochemistry and molecular biology, I mean a lot of great scientists in our field have focused on ApoC3. And so the way that we kind of look at it, it's the yin to the yang of ApoC2. So if ApoC2 is the yin, ApoC3 is the yang, and ApoC2 is the accelerator for lipoprotein lipase, and then ApoC3 is the brake on lipoprotein lipase, and it's like the balance between the two. But also, I mean, independently, we already kind of knew that ApoC3 has pleiotropic effects. So it's not just the effects in the vasculature on lipolytic activity, that there is actually, even at the level of assembly of triglyceride-rich lipoproteins, that there is an impact of ApoC3 in the liver, certainly, and then possibly for intestinal-derived lipoproteins at the level of assembly. So it's not just then the effect on catabolism, on the breakdown, like at the hydrolysis through lipoprotein lipase, but then also these non-lipoprotein lipase dependent effects. And so we think that's probably then how these drugs are working, because just as you exactly pointed out, if the main action of ApoC3 was this inhibition or a break on lipoprotein lipase, and the patient is born with essentially complete deficiency of lipoprotein lipase, how the heck does the drug work? So it is actually now through these non-LPL dependent effects. But if we go back in the literature, people knew about these before. I mean, so it's like but generally when we teach it or when we talk about it in lectures, we try to simplify it, and so we focus on the LPL effects. But anyway, there are actually several effects of ApoC3.
Do you think the inhibition on hepatic lipase, which would be removed if you removed ApoC3, might have some effect on the clearance of chylomicrons, either by remnant receptors or is that just a guess?
I think it's a good thing. There are patients with hepatic lipase deficiency, and those patients, if you stress them, they do develop like abnormal remnants. You give them like retinal palmitate and fat load, and so there's this delayed catabolism of chylomicron remnants. So that's actually a really good question. You think, I mean, those patients are very rare as well. So maybe with but that, I mean, that might be another group to try these ApoC3 inhibitors on. The main issue with the true familial chylomicronemia, so what we used to call type 1 or lipoprotein lipase deficiency, is that although technically, theoretically they could accumulate VLDL, there's so little substrate that is actually getting through because of the initial block, on the dietary fat. These chylomicrons are just accumulating to like a crazy amount, and then very little actually remnants or anything is getting through, and so then there's actually very little VLDL being made by the liver. So that's the classic definition: very high chylomicrons, normal or even low VLDL. And then everything else, LDL is almost absent, HDL is very low. So it's all chylomicrons, as opposed to say the type 5. So the type 5s, which are more common, maybe one in 500 or 1 in 1,000 in the population, where there is a partial defect in lipoprotein lipase. So you get the chylomicrons piling up and the remnants, but some of them are getting through because it's only a partial defect in lipoprotein lipase. Heterozygosity, so we find like lots of heterozygotes amongst the type 5s or multifactorial chylomicronemia. And then there's enough substrate getting through that, in fact, VLDL is being made, and in fact, the VLDL is going up, and then the same thing, it's being blocked, it's being saturated, the whole mechanism is saturated. So there you get like high chylomicrons and high VLDL. And one quick way of differentiating is actually the cholesterol level, the total cholesterol level. So in the classic familial chylomicronemia syndrome, the total cholesterol level is actually relatively low compared to how high the total triglycerides are. Whereas in the type 5 or the multifactorial chylomicronemia, there's more of a the total cholesterol is higher because there's more VLDL, and then more of the other species. But as it turns out, these drugs work just as well in those patients as in the complete lipase deficiency.
Okay, that's something I want to get back to, but because I am a geek, I'm really fascinated by the LDL story and the VLDL drop in production in these patients. So I want to just ask you a couple questions about that. So
Sure.
traditionally, we know that the ApoB levels are very low
Yeah.
in people with familial chylomicronemia syndrome, which I always thought, since most ApoB is carried on LDL,
Yeah.
that may be the reason, because without lipoprotein lipase, the VLDLs can't be converted.
Yeah.
But could you explain in a little more detail just for me?
Oh, yeah,
Why
absolutely.
is there a reduction in VLDL production?
Right. So I think part of it is just that, so that especially in children, so most of the fat, so most of the lipid content for the hepatic particles, the VLDL, which is then the source, the precursor from which LDL ultimately is made. So it's like, through the remodeling in the plasma. Yeah, so you can then either, so whatever the lipid that goes into the VLDL, it can either be like synthesized de novo from like de novo lipogenesis in the liver, or it can be like dietary fat that ends up being recycled. So it's coming in, so then ultimately then it's the chylomicron remnant for dietary fat, and then that fat gets repackaged into, sort of pre-made into VLDL, and then the VLDL gets secreted. But because that initial step, and then this is, especially the most pronounced in young patients, like, infants and children, that first step is so compromised. There's very little de novo, almost no dietary triglyceride is getting into the liver, and therefore and so then that's compromising the total amount of VLDL that is being made. When we measure ApoB clinically, we're really measuring B100. There's not really an assay for B48. So people think, well, the chylomicrons are high. How come the ApoB is not high? Well, it's because the assay is for B100, not for B48. And so then if the VLDL is low, then ApoB will be low, and then if then consequently LDL is low, I mean everything is backed up, everything is choked, and so and of course most in people with normal triglyceride levels, normal lipid metabolism, most of the ApoB is actually carried on LDL. But here, like there's like no VLDL, no LDL, or very little, and so the ApoB. So that's another way you can tell these, familial chylomicronemia syndrome patients is the quite low ApoB relative to the magnitude of the triglyceride elevation.
Okay, that was a wonderful explanation. I can't tell you how many times I've had this discussion with people and never had an answer that clear. So I appreciate that.
Okay, you're welcome.
So now that we've kind of walked through the science and the metabolism issues behind the disorder, and we talked a little bit about the unfortunate plight of the patients who've been unable to really go out and eat and have to make sure they bring their own food sometimes so they don't get any fat,
Yeah.
and they, as you know, they get abdominal pain all the time and are often falsely accused of being malingerers,
Yes.
lose their jobs, their spouses, etc.
Yeah.
So it is exciting to have some therapeutic agents that really work by these anti-ApoC3 agents, whether they be ASOs or siRNAs. So as you well know, since I think you're possibly the lead author, but at least a co-author on the Palisade study, which was a study of a siRNA drug against ApoC3.
Mm.
That's recently uh, published study.
Yeah.
So I wonder if you can tell us a little bit about that and, what kind of hope that gives us for those patients.
Yeah, absolutely, absolutely, Alan. The Palisade study was conducted using a drug which is called plo well, plozasiran or plozasiran. I think they're probably the pronunciation because it's fairly even the name that's been applied to it. There was a number previously, so when the trial was ongoing, it was ARO ApoC3, but now it's called plozasiran or plozasiran. I guess maybe like inclisiran, maybe so the pronunciation should be plozasiran. So all these, so just a quick clinical tip, that if you see these, because we're in the age of biologics now, you see the drugs that have the suffix SIRAN, siran. That's kind of a dyslexic version of siRNA, so short interfering RNA. So that generally means when you see that in any field now, that means that that's a short interfering RNA. Whereas if you see arsine or zarsen, like so olezarsen, that's an allele specific oligonucleotide. So that's also targeting RNA, but slightly different chemistry, slightly different mechanism. The allele specific oligonucleotide works predominantly in the nucleus. The short interfering RNA is working in the cytoplasm and in the nucleus. Anyway, both of them are acting to um, the way I think of it is like the instructions of how to make, say, ApoC3, that's in the genome, that's in the DNA. So that's like the repository, that's like the Wikipedia of where the instructions are. And then the cell says, okay, I need some of the protein. So then it whips off a work order, which is the messenger RNA. It's like a message, a text message. And then these short interfering RNAs or ASOs, what they do is that then they intercept the email or the text message for the work order to make the protein, and they just direct it to the deleted bin. And so then the protein itself is not being made. So one way you could say with a monoclonal antibody, you could block the protein. So that's how your mAbs work. But then here you're basically just blocking, and it's very elegant. You're just targeting only the message, and preventing the ApoC3. So anyway, both of these drugs, so olezarsen was published back in April, the Balance trial, and now this one, the Palisades with plozasiran, was just published. So I ended up being like third author on the paper. I had 3 patients in the study, and then my main involvement was actually kind of curating the genetic aspect of it. So the study was originally designed to enroll patients with the familial chylomicronemia syndrome, so actually like the genetically defined. And then later on, it was amended to include so that it was not so strict. So it wasn't just only patients with the genetic diagnosis, but even patients that then matched clinical criteria or had some other specified features, maybe was not like a perfect match genetically, or maybe never even had genetic testing, but then, did have uh, clinical features that were suggestive of FCS. So there were there were a total of let me see if I get the final number here. I think it was 74 patients that were randomized, 75 patients, and they received then either there were 2 doses, 25 or 50 milligrams, and it was there these were quarterly injections, so every 3 months, and they were randomized, so 2 to 1 for like active treatment versus placebo for each group, so it was 2 to 1, 2 to 1. And then many different potential endpoints, but the main endpoint was the triglyceride level. So the average triglyceride levels were like 2,400 for the patients in the study. About 60% of them had like definite genetic FCS, homozygous, biallelic, proven mostly in lipoprotein lipase. And then about 40% had this other, like severe enough the clinician felt they had it, maybe had some kind of clinical score, but then not necessarily genetically confirmed. really no difference between the two groups clinically. They appeared to be as severe at baseline. Um, and so then at the key time point, which was 10 and 12 months, uh, there was about a 90% reduction in ApoC3 levels in plasma, which is good. And then there was for both doses, it was about the same, a little bit more with the 50 milligram dose. And then for the triglyceride levels, uh, there was I think get the number exactly, but it was a 59% reduction in triglycerides actually for the lower dose, 25, and then a 53% reduction in triglycerides for the higher dose, 50. And so the implication.
Those were the mean reductions, right? I think they also talked about the median reduction, which was a little bit higher.
Correct. The median reductions were like closer to 60%. You're quite right. And so what they found, yeah, so exactly, it was like 60% for the 60% for the lower dose and 51%. So anyway, these were you're thinking in one sense, okay, well, they're starting with like levels over 2000. So what does a 50% reduction mean? Well, it comes down to 1000. But so you're thinking, okay, well, that's still very high. But the issue is that they also were, or we, I guess, I mean, overall, we were keeping track of pancreatitis events. And so as it turned out, there were, when we pooled together the two doses. So even though like the triglyceride levels were still high, there's this kind of clinical rule of thumb that if you get the triglycerides down to 500, then the patient is free and clear of pancreatitis risk. So here it was like more than 500 in terms of the the final level. But in fact, the pancreatitis risk went down. Like, I mean, there were the Kaplan-Meier curves, and it was a huge reduction in pancreatitis risk. It was like an 83% reduction in pancreatitis risk. So again, informative to show that, okay, so we didn't, that kind of rule of thumb level of 500. So maybe it doesn't need to be quite as strict, maybe. But the other thing is that if with these treatments, that probably during the day we're suppressing the postprandial excursions. There's probably even like, so the base, like the fasting level at baseline is like 2400. So like, just imagine, what it would be like even with a fat restricted diet during the day. And then by, treating, although this was not explicitly measured, those studies are being planned for these drugs, um, that we're reducing the excursion and reducing overall like the integrated risk of pancreatitis by not so much the effect on the fasting baseline level, but more the dynamic excursions during the day where there's the real risk of pancreatitis.
Well, that's very exciting. I mean, I always, it's not really a joke, but I always comment that there are very few lipid disorders that keep lipidologists up at night. And this is one of them
Yeah, yeah,
because you're waiting for that phone call in the middle of the night that your patient who you care about has been readmitted again with
yeah,
pancreatitis.
yeah,
So having something that, and of course, I'm assuming, I'm sure that the patients need to remain on that low fat diet despite the therapeutic agents.
yeah,
Right. I don't think anyone's kind of tested the waters of
right.
liberalizing the diet
Yeah.
with either olezarsen or plozasiran.
So what we found with we have some patients now in the open label study. So just like my patients who were in this trial, so they're now everybody is in the open label trial. And so what we have found is so generally everybody is still better off. Like there's three of them. So like one of them is actually still super fastidious about their diet. Like they're still it's like ingrained in them. And so his triglycerides are, and then everybody's getting active drug. It's like 25 milligram dose. So he's running around 150 for his triglycerides, which is like
Wow.
amazing because like he
Yeah.
was like for his whole life, and he's like, and then he went to a wedding, slacked off. His triglycerides went up to 700, but that's about the highest he's had, and The other two patients have like figured, okay, now the pressure's off. They can like, party like it's 1999 or whatever. And so they're running higher. So they're more typically around, 800 to 1,000 typically. But your intuition is correct that yeah, at least from these anecdotal observations from the open label study, is that to get the maximum benefit, they still need to be watching their diet. And so there's kind of no way around it, although it is definitely much more liberal compared to what they were used to, for sure. And even for the one patient who is like still super strict, he just says it's like a big change in his quality of life that, he can have a slice of pizza once in a while and, like with his kids and so on.
Yeah, very exciting.
Yeah.
I'm going to tweak you with one more thing because I'm excited about this study.
Yes.
And of course, we're all concerned about who's going to be able to get these medications
Yeah.
after they're approved. So we always have this sort of dichotomous discussion about multifactorial chylomicronemia versus genetically proven FCS,
Yeah.
and I know that you put an amazing amount of work into the clinical scoring system,
Yeah.
uh, but you sort of already described a third group, which we've talked about before, which is the so-called functional FCS
Yeah.
that they don't quite fit multifactorial. They don't have any other contributing factors, maybe no diabetes, alcohol, obesity,
Yeah.
etc.
Yeah.
And they act exactly like FCS, which I assume is that smaller group of patients that was enrolled in the Palisades trial.
Right.
And what do you think the future is for them in terms of availability of the medications? And will we, and just keeping in mind also the scoring system, will we have a third category of functional FCS? What are your thoughts on that?
Yeah, that's a great question, Alan. So one thing we have a paper now under review. Uh, so what we did is we took our whole population. So we had our FCS patients. I have 11 of them altogether, and then we have then MCS. So we had about 190 of those genetically defined. So those are either like heterozygous for the same genes that like where you have homozygous. So that's about like 15% of the whole group. And then there's polygenic. So polygenic, that's a different, and like half of them are poly. So the severely high triglyceride is a polygenic disease. It's like there's no single gene disorder. But anyway, we looked at them and then we kind of went down the line and looked at like every single clinical feature. So some of the things we talked about, ApoB, total cholesterol to triglyceride ratio, and like, but what we found that of that MCS, so that MCS group, there's about 8% of them where their triglycerides almost never come below 1,000, no matter what you do. So like and they're, good faith. I mean, we believe them, and then some of them have diabetes and they're managing their diabetes well, but they're always above 1,000. And there's more it's not surprisingly, more pancreatitis in those people. So that's 8% of the MCS group. And then there's other ways. There's like these rare, autoantibodies sometimes that some people can get. I think we need to better define the exceptions because ultimately we don't know like these drugs are both of them I think are now like being they're under review, and so who knows they'll. So I think the clearest indication is going to be for FCS, but then there you'll need like a genetic test, and then it's a very rare orphan disease, so that's going to be but then if it's broader, if it's then even in these, sort of more refractory cases that we all see and that we think we would love to have these drugs available to treat, but if it's going to be like a $200,000 a year drug, now we don't know, but but versus something that is more like a PCSK9 inhibitor in terms of accessibility. So that's really what I'm looking for, is to see, okay, what is the FDA going to approve it for, and what's going to be the indication, and then how does that practically roll out for us.
Well, I'm somewhat encouraged that there are other trials underway with the currently available, well, the currently investigated compounds that include patients that are genotype negative and have
Yeah,
severe hypertriglyceridemia. So hopefully,
yeah.
there's a plan at some point to be able to provide those patients therapy, right?
I hope so. I think that would be fantastic.
So, let's finish with some top line thoughts. So, uh, give us your thoughts on the impact of Palisades, uh, how it will affect your patients, and how the audience should be thinking about these agents that are effective in FCS patients.
So I think that now that there are, treatments that reduce pancreatitis, like endpoints. So we always thought, I mean, this was always, even with fibrates, I mean, going back niacin fibrates, we thought, okay, well, we reduce triglycerides in those in this patient population because we think, it's going to help with pancreatitis. So now, well, first of all, now we actually have like two treatments that work biochemically in the worst case scenario, like lipase deficiency, like, or FCS or type 1. But then the other thing is that we actually have endpoints. We have like Kaplan-Meier curves for pancreatitis. It's amazing. And so that's the I would, holy grail might be a bit of an overstatement, but at least, that's amazing to have. And that's, new hope for these patients, like you say, that have been living like decades with that kind of really compromised quality of life, that they can't make a wrong turn anywhere, with a fear of pancreatitis. So I think it's transformational, and then certainly for those patients, and then hopefully, just as you were implying, for even a wider population of patients.
Yeah, one of the things that I thought about, which, we always assumed that for those multifactorials, that when you put them on fenofibrate and omega-3 fatty acids and brought their triglycerides down, that you were reducing the risk of pancreatitis.
Yeah,
But we never had a study that proved that because we didn't have a population of patients that had enough pancreatitis to prove it. So
yeah,
really, these are the first two compounds that show that lowering triglycerides reduces the risk of pancreatitis. So that's kind of exciting by itself.
yeah. I agree.
Well, Rob, I can't thank you enough for all of the wisdom on the metabolism and also helping us understand the results of Palisades. And I share your excitement about having treatment for these patients because I indeed have stayed up at night many times with a few of these. And I would suspect that those of you in the audience, if you manage lipid patients, you will recall somebody who had severe hypertriglyceridemia with or without pancreatitis that you tried every drug on and their triglycerides did not come down. If you've been in practice long enough, you've probably encountered one of those patients. And what a hopeless feeling that is, a helpless feeling. Uh, and now having options for these patients is terrific. And if you do have those patients and you haven't figured out the diagnosis, you should certainly be thinking about familial chylomicronemia syndrome.
Yeah.
So with that, thank you so much, Rob, for your insights and wisdom. And to all of you in the audience, thanks for taking the time to listen to today's podcast.